Good evening, everyone, or whatever time of day it is where you are. It's Helena Esmond here with Vestibular First, ready for our November 2022 Journal Club. And we are very lucky to have with us Dr. Colin Grove today. So we're going to let him introduce himself a little bit further for us.
Great. Thanks, Elena. Thanks for having me. It's really a pleasure to be with you and everyone online tonight. And I'm Colin Grove. I spent most of my career as a clinician. I worked as a clinician for over 20 years. And then about 6 years ago, transitioned to becoming primarily a researcher. So I entered a DPT and a PhD program at the same time in 2014 and completed the DPT in 2016 and the PhD in 2020. And then after that, moved to take a fellowship position at Johns Hopkins in Baltimore, which is where I am now, in Michael Schubert's lab, the neuro lab for vestibular neuroadaptation.
Awesome. Well, yes, we were also lucky to have Dr. Schubert last month, so we're just doubling up here on Johns Hopkins, and we actually had Dr. Dan Gold the month before, so we're just packed full of really brilliant clinicians out of that particular facility. So thank you for joining us tonight. We're really excited to talk about your article, which you authored along with some other excellent authors. One cannot go without mentioning Sue Whitney being on a paper. Is always exciting to be a part of something that she's a part of. So, but you led the way on this, so we're really excited to have you to kind of give us some insights here, and we'll just get rolling on the topic.
Great.
So I cannot start any of these journal clubs without at least touching upon the vestibular system, just to make sure, you know, whether you're a newer person to this system or someone to whom it is really old hat, we'll just kind of point out what the vestibular system is. It's that inner ear balance sensor. You see it kind of lives amongst all the hearing structures, their neighbors, I like to say. And so, you know, we have one on the left and one on the right in most cases. That's our, you know, nice symmetry of life that helps us have backup, as I like to think of it. And we cannot mention that system without mentioning all of the other structures that have to take that information from the inner ear, send it along, you know, nerve signals to the brain, and then the brain is supposed to integrate that information with information from other systems like our vision, our joint sensors, and, you know, even hearing. All of that stuff does kind of come into play so that we can kind of know, wait, where am I? As I like to say to my patients, wait, where am I? The brain is always trying to say, especially when we have a possible problem with this system. So let's talk about vestibular screening. So the article tonight, we're talking about the Gait Disorientation test. And it's kind of described a bit as a screening tool. So my understanding of a screening tool is that it should be simple. It should be something that perhaps someone with a bit less experience or training could do. And it's a way to kind of sort out, you know, what next? So, you know, should this person be seeing a cardiologist? Should this person be, you know, getting further workup from a standpoint of imaging versus kind of other specialty tests for the vestibular system? And a good example of a screening is the VOMS. So I know the VOMS may not be something that you have specifically studied, but I'm very sure you're familiar with it. So if you could just kind of talk a little bit about, not necessarily what the VOMS is per se, but why you would maybe compare your Gait Disorientation test to the VOMS, or why not?
That's a great question. So thanks. Yeah. So they're both of the tests are, you know, the main goal of using the test is to try to screen for dysfunction relative to a specific pathology. In the case of the VOMS, it's concussion, and in the case of the Gait Disorientation test, what we're trying to screen for is the presence of a peripheral vestibular disorder. So in that sense, they share that common goal, trying to identify persons that have impairments related to a specific disorder or condition.
Great. Yep. And don't worry if you're not sure what the VOMS is, or you want to learn more. We have lots of concussion talks coming up in the next couple months. So one on return to play in academics, which should be very exciting in December, and then some excellent discussion about different visual issues after concussion in January with Becky Bliss. So should be really good stuff coming up. But for now, we want to talk about this screening tool, this Gait disorientation test. So why? Why should we use spatial navigation as a screening tool? Because that's essentially what this test boils down to. We'll get more into the details on it soon. But, let's look at the background, which kind of is covered in the beginning of this article. Why would you want to use spatial navigation as a screening tool?
Yeah, so there actually over the past 2 decades or so, there's been a lot of work that's gone into trying to identify appropriate screening tests to identify individuals with vestibular dysfunction. And many, many tests have been evaluated in terms of their sensitivity and specificity, for example. So their ability to detect a condition when it's present, that sensitivity or specificity. And most other tests, all other tests really, have come up short in their ability to identify people with vestibular disorders. And it's been tests like posturography, for example, or gait tests like the dynamic gait index, or a clinical bedside test like the head impulse test, for example. All of those have been looked at in terms of their ability to screen for vestibular disorders. Up until this time, no one had looked at whether you could use spatial navigation or spatial orientation tests to screen for a vestibular disorder. And because issues with spatial navigation, spatial orientation are so prevalent in people with vestibular disorders, we thought that it might be worthwhile to look at screening using that type of a test. Now, the test that's often used for looking at spatial navigation is something called the triangle completion test, which is a test where the person is blindfolded and they're guided to walk along the first 2 legs of a right triangle. And then once they get to the second corner, then the examiner lets go and says, okay, now turn and walk back to the origin. So the test has a rotational component. They have to make the turn. It has a translational component. They have to walk along the hypotenuse of the triangle, and they're told to stop when they think they're back at the origin. And so it has an accuracy component to it too. That test is somewhat challenging to try to implement in clinical settings. Mm-hmm. So we wanted to see if we could do something simpler, a little less complicated. And for us, that meant just having people walk in a straight line, as you do during another common test in physical therapy, the functional gait assessment. And so that's what the gait disorientation test was actually derived from, was from the FGA.
Perfect. No, absolutely. And I think it's really, I think the literature you're referring to as far as, spatial orientation is fascinating. And also, people are going to immediately probably come back with, knowing where you are in space has to do with other things besides your vestibular system, your cognition, maybe your memory. So maybe you could speak a bit to like the challenge to disentangle the layers of the onion, as I like to say.
Yeah, it is. Navigation is a multifaceted concept, right? There's a lot that goes into it. Spatial memory goes into it. Confidence in walking goes into it. There's sensory inputs that are going into the system to tell you where you are in space. So somatosensation, vision, if you have your eyes open, but not necessarily if you're navigating towards a point that isn't seen. So if you're navigating towards a point far away. So there's lots and lots of things that go into spatial navigation. But when you break it down and try to break it down into its components, parts, so you can do something like the triangle completion test either on foot, or you can do it with a person seated in a wheelchair, for example. And so if you do it that way, you're taking out the somatosensory feedback. So you can sort of tease those apart. You can do it without hearing input. So you take away any references that a person might get from, hearing their footsteps or hearing the sound of their footsteps echoing off the walls in the environment that they're doing the test in. And actually, that's how it's best done. So you have people wear noise reducing headphones when you're doing the triangle completion test, for example. So you can sort of, by taking away a sense, you can boil it down into its component parts. Now, that doesn't mean, for like the test like the Gait disorientation test, which is walking eyes open versus walking eyes closed, that doesn't necessarily mean that a person who has peripheral neuropathy might not also do poorly on that test. And so one of the things that I think that's really important to keep in mind is who is in this study that we published, the kind of person that was in that study, and who is the person that's sitting in front of you. Who is your patient, and what are they coming into the clinic with in terms of their past medical history, for example. And so a test like the Gait disorientation test is going to work best for a person who you have a suspicion already that they have a vestibular disorder, and that they don't have peripheral neuropathy, for example, and that they have normal cognitive function, for example. So you can apply it to the right person, that knowing that your results aren't going to be confounded or confused by some of the other things that patients come in with. Because patients always come in with something else, right? There's no such thing as a straightforward patient, I don't think. Everyone has baggage, as I like to call it.
Right. Yeah, it's a rare thing. But, I have many mottos, and one of them is work with what you got. So, we'll do our best to apply assessments to a patient that seems to be the best fit we can make it. So you're describing your population very well already. They were coming in with documented vestibular loss, unilateral in nature, just to make sure everybody's on the same page about that. Sometimes there could be damage to both inner ear systems or nerves, usually, versus on one side. So we'll talk a little more about what that might have meant if you had looked at bilaterals. But for the moment, you were looking at unilaterals. Am I understanding that correctly?
We had mostly unilateral patients in the study.
Okay, got it. Primarily, okay. And then you did exclude folks with some musculoskeletal or neurologic issues. So, I think again you're looking kind of to at the moment just kind of purify your group a little bit.
Right.
Is that right? Yeah.
That's how you have to start. When you're doing something like this, you have to start with a pretty clean sample, pretty clear definition of your patient population.
Right. Because somebody come in with significant knee pain could change, how they would handle something like this test. So I hear what you're saying. Understandable. Right. And so you did validate with the second group in Utah, I believe, and they were all post unilateral resection. Is that correct?
That's right. Okay. Yeah, they all had a unilateral vestibular schwannoma resected about 4 to 8 weeks prior to the time that they were tested at Utah.
Perfect. So that was a pure unilateral group versus your other group had a little bit of bilaterals, but mostly unilaterals.
Yeah, just a couple.
Got it. All right. Perfect. And then, you did have some healthies for comparison as well, the controls, if you will. So always nice to see that, so we can get a better sense of what's going on here. So you did lots of nice data collection. Always love data collection. So we have a lot to look at and compare. We're going to talk a little more about some of these for those who might not be familiar, but this is kind of the master list of what you looked at, and we can talk a little more about why when we get to the specific tests in detail. But they're definitely, I would say, in summary, some of the most well-validated, well-supported, assessments in the group of unilateral vestibular hypofunction. Would you say that was why you selected them?
Well, that is definitely one of the reasons. Yeah, we wanted to test people on using tools that had been validated in persons with vestibular disorders. That was one of our primary goals. But we also wanted to, since we were doing a test like the functional gait assessment, which was what the GDT's parent test is, and because that includes sensory challenges, we wanted to do a test like the sensory organization test in posturography, so that we were also looking at how sensory inputs affect balance and not just gait.
Perfect. Yes, absolutely. All right.
Yeah.
So let's get down to it. What is this test exactly? And you've kind of alluded to it in a very simple manner already. Eyes open, eyes closed, walking. So let's get into a little more of how you'd like to see it done and make sure I've got this right. So, you could be doing it in the context of a functional gait assessment, or you could do it standalone. Is that right?
That's right.
Okay. And you're essentially going to have a person walk. Ideally, you've got kind of a lead time and a lag time, or whatever you want to call it. They're these kind of like start and end, so that you don't capture like when they're kind of speeding up to their usual gait speed and they're slowing down when they know they're at the end, kind of thing. So you're trying to capture that.
Exactly.
Right?
Exactly.
Right? Okay. Good,
That's
good.
perfect. Yeah, you're timing their steady state walking speed. Mm-hmm.
Excellent, excellent. So you've got meters. For those of you who are into feet, it's an easy conversion. It's 20 feet for kind of the pure, that kind of 2 meter to 8.096 meter there. And then if you cap on the endpoints, it's a total of about 33 feet as I calculated it, if you're able to do that. So that's what this looks like. Again, you're going to have some kind of markings or knowledge of where those start and end points and all that are for yourself. Some folks have argued that you don't want the patients to know kind of where you're starting and stopping timing. Others folks don't seem to think that's as important. What are your thoughts on that?
Yeah, I'm not too concerned about it. The person already knows that you're going to be timing them, and so that's already on the table. And most likely they're going to hear the stopwatch start if you're using a stopwatch. So I don't think that's a concern for me.
Okay, great. All right, yes, and so kind of again, those end caps are not timed, and you're just timing that kind of distance in the middle there.
Yep.
Safety considerations that are well outlined. We don't want to lead the speed, so we want to be a little bit behind. But of course, close for safety, guarding in case they do lose their balance, especially with the eyes closed, and make sure they don't run into anything. So we are going to, stop them before they get to a wall if they really kind of go laterally or into furniture or what have you is in the area. You mentioned the sound, and that is mentioned here as well, not to talk and to minimize ambient noise, to minimize any distractions or kind of auditory cues. And if they open their eyes, begin to fall, go outside of the width of the path that's set, or like are grasping for something, you should assist them. Now, do you assist them and continue timing? This is a question that has come up.
Yeah, so if they are going to collide with something, or if you have to catch them, if there's a safety concern, then at that point timing stops, and then you can repeat the trial.
Got it. Okay.
We want to take their best response. We did up to 2 trials in this study. Most people were able to complete it on the first trial.
Got it. Got it. Okay.
Yeah, and I think you've outlined the safety considerations well. You want to be close enough to be able to catch someone, but not so close or positioned in such a way that you're leading them or maybe inhibiting their movement. You also want to be positioned such that you can clearly see when their foot crosses the timing mark, so that you can time it accurately.
Right. Yes.
Yep.
Perfect. All right, so we're calculating after we do this kind of trial or 2 trials, eyes open, trial or 2 trials, eyes closed, somewhere in that genre. Probably the eyes open you wouldn't have to repeat too often, I'm guessing. Otherwise, this is not the test for that person, just a thought. Right? And take that and do a little math problem that's very easy. I just gave an example here. If they took them 15 seconds, eyes closed, and took them 8 seconds, eyes open, you subtract it out, boom, 7 seconds, which is greater than the 4.5 second cutoff that you found discriminated those vestibular impaired from healthy adults. Got that right? Okay.
That's right. Perfect.
Good. All right.
We thought that having the test constructed using a simple subtraction was going to be much more friendly than having, for example, needing to divide the times. So, yeah, and it turned out that the subtraction method was really very accurate, as you showed.
Wonderful. We like it when it's simple. That's a good thing.
Yeah. Yeah.
Some tests I think are almost prohibitive when they start to have like a complex math problem involved to sort out the
Yeah.
score, right?
Yeah.
So, all right.
No calculus involved here.
No, exactly. Now, I think the pros to me are obvious, and we'll see if you want to add any to this list. It's already within the functional gait assessment, which many clinicians do regularly, so they're familiar with it. It's really straightforward. The instructions are really written out in a way that you're supposed to read them out, one by one. So again, it's really kind of laid out for the tester. And also, I would say within that is even if you hadn't done the FGA before, walking with someone and walking with them with their eyes closed isn't, again, something that requires on the tester side much training. So it's really, quick to perform, and you don't need like extensive training to be someone to be a tester for it.
That's right.
Having that discerning 4.5-second cutoff is really nice. That makes it very attractive because people kind of like something hard and fast that they could use to show deficit, objectively. And then also having a minimal detectable change you mentioned is 3.7 seconds. So what else would you add to this list, or how are we doing here on the pros?
I think those are all pros to the test. I don't know what you're going to have next, but I think other pros are that it can be, because it is so simple and there's so little equipment and training involved. We think that just about any member of the care team that's had appropriate training in terms of guarding patients, for example, I think just about anybody in the care team could perform this test. So, for example, it's potentially feasible for an MA in a geriatrics falls clinic to perform this test and then report the results back to the provider so that they can be, interpreted and discussed with the patient, for example.
Perfect. Yeah, and that goes back to its value as a screening, in my opinion, something that really could be broadly used, and then, lead to the right next steps. So, we think they have a vestibular impairment, perhaps they need, vestibular rehab, or maybe, if we're not sure why they are presenting this way, should we get them some sort of medical exam to address that, or, especially if they're complaining of dizziness or some other related symptoms, right?
Right. And on the psychometric side of things, in terms of pros, it's a simple test, but it's really powerful. The psychometrics are very, very, very strong. So.
Very good. All right, perfect. That's what I wanted to hear. Good. All right, So I had to point out the limitations, or we would not be complete. I'm sure you're familiar with them. So, we will acknowledge them. So the patient has to be ambulatory at a level safe for gait, eyes closed, and willing to perform. So you might have someone who's too anxious. I've had a couple in my career. What would you say? Is there anything like, if they, walk with a certain device, I wouldn't do it? Do you have any kind of like personal thoughts on, what might be a decision maker for you, or kind of what leads you away from that?
So we tested people based on the guidelines for the functional gait assessment, which means that theoretically they could have been allowed to use an assistive device during the test. That would have affected the scoring component of the FGA, not the timing component of the FGA, though. And so we really haven't sorted out whether using an assistive device affects the timing component yet, but it's interesting to think about. So I think that, based on what we did, it would be appropriate to use an assistive device. We don't know, though, whether or not that 4.5-second threshold would hold up for people that are using an assistive device. So I'd say some cautious interpretation might be needed if the person's using an assistive device. I think as you mentioned, anxiety is a significant consideration. But I try to, when I administer this test in the clinic or the FGA in the clinic, I'm giving the patient very clear instructions and I'm
Mm-hmm.
letting them know that I'm going to be right in front of you. I will prevent you from colliding with anything or from anyone else from colliding with you. And I haven't had anybody refuse to do the test because of anxiety, but I can see it in their behavior when they do the test though.
Right. No, fair enough. And I think I'll say, mine were, it was a very limited group. It was only two people in my, 15-year career. But I will say that I think there's no question that education, and I don't do the FGA first, right? So, like, usually I've done some other testing and we're building rapport. um,
Hmm.
and I
Hmm.
would personally say that, it's my opinion, that can be a factor that by the time you then get to this walking test, you're like, all right, this is going to give me some really good information, kind of like why they need to do it a little bit, not like to be overselling, but, just kind of
Hmm.
let them know. I think you could be pretty successful. And you don't need to do it 10 times in a row. I think that's another thing um, that is good to be aware of and to maybe reassure them, that really, in most cases, you shouldn't need to repeat, right?
Right. I don't, the only times that I have to repeat items on the FGA, for example, if they need to be repeated, or maybe the person um, did not follow the instructions. Either I gave them poor instructions, or they just didn't make sense to the person, or they uh, looked like they were at risk for falling and I had to catch them, for example. So,
Sure, sure. I wouldn't say
mhm.
gait with eyes closed is one of them, but I do. I'm a demoer. Like when I do the walking with head turns, I always show what I want first,
Mhm.
because especially since some of them have hearing issues anyway. These patients,
Right,
it's kind of nice to give them the visual.
right,
I think so.
right.
Yeah,
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 that's always a good idea. And and you said educating them before you do the test. Okay, now we're going to do a test of walking, and it has 10 items, and it's going to tell me about things like how at risk for falling you are, and then you march through the items.
yeah. Perfect. All right. It does require a little bit of space. So, for people who are really tight on space, this, may not be a feasible test, but hopefully most of us can, squeeze out at least 20 feet. And ideally, we've got a little more room for that lead and end cap, distance as well for the 33 feet. So,
Yeah,
that's a,
standard therapy gym should work fine, but also a hallway. Obviously, the issue with being in a hallway is you never know which one of your colleagues is going to pop out of the door at that particular moment when the person's walking with their eyes closed. And so you just have to have an understanding with everybody that how
yes,
you're going to play together in the sandbox. So.
that's right. That's right.
Mhm.
So a big one here, and I think that's just because this is a brand new test, so it's not fair to say this, in a negative way, but just to say we'd like to see what the applicability will be to possibly other vestibular conditions and other balance conditions aside from vestibular hypofunction. So that's just not yet known.
Right. There's at this point in time, there's only one other study looking at its applicability in pediatric concussions. So that paper was just published within the last month or two, I think, out of Pittsburgh. And so we're starting to see some other populations being studied with this test, but just at the very beginning.
Right, right. So I'm sure it'll come around. But yeah, so we'll look forward to that and check that out. But last but not least, that there are patients that have, say orthopedic or neurologic conditions, and so, we're not sure, how applicable that we'll be able to, use this test for those groups, or will there be any kind of cases where that wouldn't make sense or wouldn't really give us the information that we're looking to get. So,
Hmm.
I'm sure that'll be something also on the roadmap of kind of seeing what plays a role and maybe what doesn't actually turn out to play a role. Um, so TBD, right? Exciting new research always has more questions. I'm sure you can
That's right. That's right.
vouch
And
for that.
I'd say, just I would add to that, consider that at present, the FGA is being performed in a variety of patient populations. It's been tested in a variety of patient populations. And So we're already doing this comparison of eyes closed versus eyes open walking in different types of patients. What we don't have, though, is a clear threshold to know that, if the test result is greater than, in this case, 4.5 seconds, for example, that actually tells you something about how disoriented they are with walking. You may still be able to make a judgment about it as a clinician and to say, boy, they really are lost in space when they try to walk with their eyes closed. But to have a hard number to go with to actually make a comparison, that we don't have.
Yes, not yet, but
Not
more
yet.
on the horizon. All right, very good.
That's right.
All right, so we're going to talk a little more about these other outcome measures. And I wanted to do this because I think that, again, even with these well-established tests, the literature seems to always be evolving. So we're going to start with the ABC. For those who are not familiar, make sure I try to get all of these abbreviations right. You can correct me anytime if I get it wrong.
Right. Mm-hmm.
So the activity balance confidence scale. Have I got that right?
Close. Activity-specific balance confidence scale.
Perfect. All right. It's a lot. But at any rate, it's about balance confidence. That I'm sure of. Confident
right.
on that. So, at the pro side, it's got a nice cutoff that is pretty easy to remember, I think, which is, kind of less than 2/3 or 67%. Is considered to be pretty broadly indicative of falling in multiple groups to some extent. There's variation, of course, amongst diagnoses a bit. If you want to dig into rehab measures, that's a website that always has lots to offer. But it is recommended by the Vestibular Evidence Database to Guide Effectiveness, also known as VEG. Which is a wonderful work group that put in a ton of time on looking at these different tests and outcome measures for physical therapy primarily, although many of these can be used across disciplines and should be, I would say, because they can give us some really valuable information. So another reason I like it is because it highlights specific tasks that are difficult, so you kind of really get a sense of like, oh, this person really feels uncomfortable reaching, like, at least from a therapeutic standpoint, I'm thinking we might need to work on reaching, for treatment. So it kind of, gives some hints as to maybe what you don't get in an interview or a history sometimes that you want to get more information. And cons include it is subjective report to an extent. It's what the person's saying about their balance. So, and it's looking at balance, not dizziness. So I'm curious to you, are there any times where you would do the ABC and then kind of almost throw it out? Like the person is saying they're very confident and that's not matching with your test.
Well, I'm glad you brought that up because that is something interesting that we see in the clinic. It's not uncommon to have somebody score a 90% on their activity-specific balance confidence scale. So they're saying they're really confident in their balance. And then you test them with something like the dynamic gait index or the functional gait assessment, and they don't test well. They test at a high risk for falls. And so there's this discrepancy between their perception of their balance and what you can test as far as their capacity in their imbalance. And so I don't throw it out, but I do note in their chart that there's a discrepancy there. And sometimes, and you've probably seen this too, Helena, and maybe many others that are watching tonight, is that a person's ABC score goes down with therapy. It gets worse with therapy, in part because what you've helped them realize is that they really do have an issue with their balance. And so they become more aware, more self-aware of their actual abilities. And so typically if you're trying to justify therapy to an insurance company, you want your outcome measures to get better.
Yeah.
But sometimes the ABC goes down, and it's understandable why, and it's not necessarily a bad thing that it goes down. It's you have helped that person realize the situation that they're in, and then that may be one of the factors that leads to behavior changes that increase their safety.
Right. And I think the flip side can occur. So you've got patients who test well, but by their
Right.
perception, right?
Mm-hmm.
So either because they're
Mm-hmm.
very afraid of falling, and it can have a lot to do with the fact that luckily balance relies upon many things, not just our vestibular system. So I have someone
Right.
coming in with a whatever vestibular condition, say unilateral hypofunction, and they're like, "Oh my gosh, this is so different. I don't feel right. I'm off." Fill in the
Mm-hmm.
blank on the verbiage, but like, they
Yep.
test, fine, like in that we don't think that they're gonna fall, but on the flip side, they don't have that confidence because they know what they felt like before, right? So it's all comparative,
Right.
right? You've got an athlete, they can top out on almost any balance test, and we see this with concussion, which is why some other, higher level balance tests have been kind of developed and are being tested at
Yeah.
various points still. But
Yeah.
I'm sure you know what I'm talking about here. So
And
it's
those
tricky,
are
but
and
it's
those are
nice.
those are very different patients, right? And how you approach those patients is very different in your therapeutic approach. That rapport that you're trying to develop. And I think you've touched on another really important point, Helena, and that's that you really have to know the person that's in front of you. You have to know them well, not just their medical history or their information that's in their chart, but you have to sort of get to know them and who they are too. So yeah, good point.
Right, and this is where the science and the research, it almost has to always be about groups, right? And let's look at the averages and the means and all the statistical variance and whatnot. And of course, we have a person sitting in front of us that's very individual. So it's like this kind
Yeah,
of tricky thing
right.
to say, how much can I use the literature, and that's why I always tell clinicians that I teach, it's good to have kind of a structure and a guideline and a sense of what we should be doing, but then you've got to no cookie cutter, please. Like,
Right. Right.
right?
Right.
Yeah. Yeah.
Yeah.
All right, perfect. So DHI is next on our list. Dynamic, the dizziness handicap index. I want to get these. So it's nice in that it has kind of mild, moderate, severe grading. It has a minimal, clinically important difference, which I love a little more than detectable change because, of course, it kind of gets that what's meaningful.
Mhm.
Highly recommended by the vestibular work group, and predictive to an extent for BPPV for certain elements, which is nice. So I know, actually, I believe Sue Whitney was involved with that work on,
It was. Mhm.
right. So kind of these
Mhm.
positionally specific provoking movements that, can be predictive, not a guarantee, of
Mhm.
BPPV. So
Mhm.
those are all great things about the DHI. Again, it
Right.
is a person's report, which doesn't invalidate what they're experiencing, but doesn't, always point us to a definite diagnosis. Because I've had people score 100, right, which is the top score, just in case you're not familiar out there in the audience, so to speak. So 100 means that everything makes them feel dizzy and they're really feeling bad all the time. So that doesn't tell us a lot at that point when they're kind of topping out on the scale. The 11 on, it's
It
not
does.
good.
Yeah, it does tell you some things about your patient. Um, one of them being that their prognosis for recovery is probably not as great as someone who has a score of less than 30. People that have astronomically high DHI scores, um, there's a lot of issues going on there, and those issues tend to affect their recovery. And I think you made another point just a second ago about minimally important, minimally clinically important differences versus minimal detectable changes. And both of those both of those numbers have value, right? So the minimal detectable change is telling you how much does a person need to either get better or worse for you to be able to detect that has happened
Mm-hmm.
outside of the measurement error of the test. So every test has a certain amount of error that is sort of baked into the test, if you will. And so the MDC tells you that, okay, their change was at least more than the error that's baked into the test. And then the minimally clinically important differences, those are challenging to come up with because that's based in part on opinion, right?
Mm-hmm.
And people's opinions can differ as to what's clinically important.
No, definitely.
Yeah.
Yeah, and the other thing about the DHI that we kind of would recognize and maybe steer us towards something like the situational uh, vertigo scale
Oh,
or
situational characteristics
yes,
questionnaire. Yeah.
yes, yes, exactly.
Yeah.
Something else that looks at visual motion sensitivity or self motion sensitivity. We just have to kind of be conscious when we're choosing, trying to get a sense for the patient. I know sometimes people have these paperwork situations filled out in advance of them walking in, so you might have to have them fill out something for the next session or something. But it's just kind of nice to really kind of pay attention to what would actually kind of capture,
Hmm.
what's going on with the patient a little more fully. So,
Exactly.
looking at balance a little bit, the functional gait assessment, which again has the gait disorientation test embedded in it, so that's awesome. It's already there.
Hmm.
We have a cutoff of 22 or less, indicative of increased fall risk. We have a minimum detectable change for vestibular specifically at 6 points. So this is good for goal writing for physical therapists. So we do care about having something like that to help us kind of something realistic goals and valuable goals, something that's objective, and of course we still have subjective goals that our patients maybe would like to see improve or change as well.
Yeah, yeah, that's exactly right. And when you're applying a number like that, 22 out of 30, it's important to know who that's meant for. That that's meant for community dwelling older adults that are otherwise healthy. So it's not targeting people with vestibular disorders, for example. And so it's to apply that to somebody with a vestibular disorder may not be appropriate. And the research just hasn't been done yet to develop falls risk cutoffs for other populations for that test. Um, the other thing that I would say is we ran receiver operator characteristic uh, analysis of the FGA, and that's just a fancy way of saying, can the FGA detect falls risk in our group of healthy versus people
Mm,
with vestibular disorders? And the cut score for our group was 27, but it was
mm.
terrible. It was terrible in terms of its sensitivity and specificity. So even though we got a cut score, it's really not worth using. So more research needs to be done on that for sure.
For sure. And for me, I just know that if someone comes in and we do an FGA and they do hit 22 or under, whether they have a vestibular issue or not, I'm putting that in my cap to say, like, okay, I don't like that. Now, that doesn't mean if someone scores a 27 that I don't treat them. It just means
Yeah,
that,
right.
is maybe not something that we need to focus on as much as their symptom report on the DHI or, something
Hmm.
more specific. Again, maybe a higher level balance test if we need to, something like that. So just
Yeah,
got to really be, again, a little bit individualized to a degree. Um,
sure.
so the SOT, just so everyone knows, sensory organization test is considered to be a technology test in my head. It's got some kind of posturography associated with it. There's a few different brands out there. And the poor man's SOT is what's affectionately known as the modified CAT-SIB,
Yep.
right? The clinical test
Yep.
for sensory integration, right? So different ways to try to look at eyes open, eyes closed, uneven surface or moving surface, if you will, versus a firm surface. And then the SOT adds that visual conflict. So here's a question for you.
Hmm.
You know, Neurocom is one out there that's kind of by the wayside. Do you feel like SOT is being used, isn't being used, mostly in big places that can afford a bigger machine? What are your thoughts on that?
The test is definitely still being used, and as you said, the company that bought Neurocom decided not to continue to develop that system and to let that product line go, and so it's not possible to get a system from that company anymore. The original developers of the SOT, though, partnered with a new company that's out there and is rapidly taking over the space. Their machines are popping up in clinics all over the place, and so that new system is different than the old system. So instead of the if for people that are familiar with the original sensory organization test, the person was standing effectively in a little telephone booth, and then that telephone booth would move forward and backwards with them at certain times during the test to look at how well a person could use or ignore inaccurate visual cues. In the new system, instead of being in a moving telephone booth, they're standing in a virtual reality dome, and there's an image that's projected onto that dome, and the image is what moves with them and creates that sensory conflict of, challenging the person to either use it or ignore inaccurate visual cues for balance. The force plates are a little different between the systems too. So it's definitely out there. It's being used. In another one of my studies, I did a head-to-head comparison of the original sensory organization test and this new version of the sensory organization test. And one of the things that we found importantly is they are not the same. The sensory organization test results that you get from the old system are different than the results that you get from the new system. And so it's important now that more research is done to identify new normative data for the new SOT so that it can be used appropriately.
For sure. And with that, even more on the horizon, I know there's some early work on, kind of the idea of using some sort of virtual reality system, goggles,
Right.
kind of headset-based for an SOT. So that
Yep.
seems to be still
And
kind of
that's
in
and
the
that
research phase, right?
Yeah, that's in the research phase too. That system that's the primary market leader in that area is also using the original Neurocom norms for their product, and so that's another system I think that's going to have to be normed with new norms just for itself.
Got it. So technology pros and cons. So me, I don't have
Right, and
any of
as
that.
you said, it's super expensive, right? So
Right.
those systems are over $100,000.
Right.
And that's not something that every PT or every ENT clinic can afford or wants to shell out money for. The interesting thing, just to bring us back to the Gait Disorientation test,
Mm-hmm.
is the Gait Disorientation test performed as well at identifying people with vestibular loss as the SOT.
Woohoo.
So your stopwatch is as good as a $140,000 piece of equipment as far as screening for vestibular loss goes anyway.
Yeah, I like it. All right,
Yeah.
good. Okay, so 5 times sit to stand test. I'll just say it's not something I use as often for vestibular patients. I was interested kind of in your rationale on that really briefly.
Yeah. So it has been evaluated in individuals with vestibular disorders. We were using it primarily as a test of functional leg strength. It was a part of our screening. We did a clinical exam on everybody that was extensive. It included ocular motor testing, it included positional testing, it included the 5 times sit to stand also, and that was our determinant for lower extremity strength. One of the criteria for being in this study was that people had to have normal lower extremity strength, and so
Perfect.
if people scored within the normal values for the 5 times sit to stand, then we could say they had, in a sense, normal lower extremity strength. Although there's more to the test than just that. So.
Sure. Well, that's a good way to use it. I like it. And then the horizontal head impulse test. I'll just say it's a bedside test. It can be done quickly. There's a few reasons maybe why we can't do it, but for the most part, I'd say it's very commonly used to try to help identify unilateral loss. But I'll just emphasize for those who are not familiar, if you feel like you saw a negative on both sides, that doesn't mean that they don't have a hypofunction. Yes, you're on board with
That's
that?
right.
Okay.
That's right. That's because the sensitivity of this head impulse test is not good, and the specificity is great. So if you get a positive head impulse test, pretty much guaranteed the person has a vestibular disorder. But if it's negative, you don't know. And there's a variety of reasons for that. We had a sensitivity of about 72%, 73% in this particular study for the head impulse test.
Got it. All right. Head shaking, even I would argue less. Not that's not helpful, but if it's negative, I'm not saying, oh, they definitely don't have a hypofunction. You're nodding. Yeah.
That's right. That's right. Because the underlying mechanisms that drive a head impulse test or a head shaking nystagmus test to be positive, to be abnormal early on after a vestibular disorder, those the brain compensates for over time. And so these tests tend to become normal over time as the person is recovering. And so in the one sense, it's a good thing. You know that their central vestibular compensation is happening, that it's underway if these tests are no longer positive. That's one way to look at it. There's a little more to it than that, but
No, it's good. It's good. And I think it helps because folks, I feel like sometimes they treat everything as like yes, no. And if it's no, oh, they definitely don't have, and I'm like,
right, right.
I know it's
Yeah.
frustrating because the clinician wants a straight answer, and I respect that. But that's why we got to take all our information and try to say, okay, what makes the most sense here? So, dynamic visual acuity
Yeah.
test. I think this is underdone. I know lots of clinicians who don't do it on the regular. I mean, instrument is great, and if you don't have instrumented, I think it still has some value. So I would be interested in your thoughts on that.
So I did the non-instrumented version of dynamic visual acuity for 20 plus years in the clinic and found it to be extremely valuable. There are some advantages to the instrumented tests in that, for example, with an instrumented test, the person is only going to be able to see the letter if their head is moving fast enough. And so that's definitely an advantage. But if you structure the non-instrumented test well, so if you have a standardized eye chart, for example, the early treatment diabetic retinopathy study eye charts or the EDTRS eye charts, those charts have advantages over a standard Snellen chart. The Snellen chart is the one that has the big E at the top. If you use an ETDRS eye chart, there's the same number of optotypes per line, and they decrease at a specific amount per line. And so it definitely has some advantages over the Snellen chart, which has different numbers of letters and size changes between lines. You can also use a metronome to help you with the pacing. And then people have actually looked at, do you improve the reliability of the test if you have something on either side of the person's head so you know how far to turn the head back and forth each time. But I can tell you in the clinic, I did it for decades with a metronome, and the only patients that I didn't feel like I was getting accurate results with were patients, for example, that had a lot of guarding. They didn't want me to move their head, and they would walk their head down. So I'm trying to move it, but it's not moving very fast. And you just know then that you're not moving at the requisite speed in order for testing vision when the vestibular system has to be helping.
Right. No, I agree. No, I think it's a really valuable functional test of what's going on with gait stability. So I love it.
Yeah.
Hot off the presses, just want to let everybody know, you might have seen this come out from Dr. Schubert was on this article as well. The minimal and clinically important difference in gait speed for unilateral vestibular hypofunction, the exactly group we're talking about, between 0.2 and 0.34 meters per second. So you guys put that in your bucket. You're already doing gait speed with the gait disorientation test. So this is like money in the bank, something else you could use to maybe write a goal about if you're in PT or you just want to identify, what might be something to show progress or, things like that. So think about that, put that into your, just wanted to put this in. I know it's not in your article, but just
okay.
Good to mix it in because it's so relevant, right?
It's from the same neighborhood.
Exactly. So wrapping up here, we're almost ready for questions. I'm just going to talk about a vestibular exam as a whole. So, we're definitely, to me, gait disorientation test should be even in almost your briefest exam. If you got 15 minutes, this gait disorientation test only takes a couple minutes of that. So if you have a whole bunch of time, we know there's tons we can do. You're asking all kinds of questions, trying to identify things like, do they have signs of migraine? You can certainly dig in an hour. And I have a whole bunch of information about what that could look like. Hopefully this is all stuff you guys have seen in a course or something that you know about to do testing on. But if we have less time, right? So, and I'm going to take, just kind of a quick thought as to whether you would take away or add anything. If you only have 30 minutes, Dr. Grove, is there anything you would take away or add from this list?
Let's see here.
I've got history, getting your timing and triggers, associated symptoms. You've got, if you don't have an SOT, you're going to do that modified clinical test for
Yeah.
sensory integration or
Yeah.
balance, gait speed,
Yeah.
and a gait
Yeah.
disorientation test. You're going to do your basic ocular motor
Yeah.
exam,
Right.
vestibular exam,
So I
and
think,
yeah.
yeah, I mean, you've started off with the most important thing. So history, and I would say I spend whatever time I have available to me, I'll spend a quarter of it on history. So along as, if that's an hour, I'm spending a 15-minute period of time on history. So if it's 30 minutes, I'm going to spend 7 or 8 minutes on history, for sure. And then I think that you can get a lot of information just by looking at head posture, for example. That can give you information about whether the eyes are positioned well. If someone has a misalignment, that can tell you something.
Mm-hmm.
For the ocular motor exam, if I could only do one test from an ocular motor perspective, I would do saccades, because
Mm-hmm.
they're the most sensitive at detecting specific problems within the nervous system. I definitely want to look at spontaneous nystagmus in room light if it's there, and with fixation removed with a pair of goggles, because that's key. I would do, if I could only do one balance test, I would do the modified CAT-7.
Mm-hmm.
If I could only do one gait test, I would do the 4-item dynamic gait index. So that's what I would do. And then if I had time for positionals, I would do Hall pike tests before I would do lateral canal tests.
Perfect.
Yeah.
All right, good. So, we boil it down to 15 minutes. We just take some things away. I know that the MCAT-SIP is great. I really need to see gait personally if the person's ambulatory. So actually, I would say that if I had to choose between I could only do an MCAT-SIP or I could only do a gait disorientation test, that would be my call, because I need to see gait. If I didn't get to see them walk in, it just depends on maybe your circumstances. But I think seeing gait, gait with eyes closed, a gait with a head turned, something, right?
Yeah, and I think it depends on which one I would choose. Depends on what my goal is. So if my goal is to determine a person's falls risk very quickly, then I'm probably not going to use the gait disorientation test, because we don't know what the falls risk cutoff is. But if my goal is to determine whether they have a vestibular problem or not, and I've already done a head impulse test as part of my vestibular ocular motor exam, and that was negative, but in the back of my mind, I'm thinking, man, this person's history sure sounds like they have a vestibular hypofunction. I'm going to pull out the gait disorientation test. Yeah.
Perfect. No, and I think that's a good example of where your shortened test is going to depend a little bit on, what history you have, what, else you might want to kind of focus on. And I just wanted to mention, the acute care folks and emergency room folks, I don't forget about you guys. There's some good literature on things like standing, which, kind of pulls together the HINTS exam, which is involving the head impulse test, looking for nystagmus and spontaneously. And looking at test askew, just trying to kind of differentiate for acute, vertigo situations. Are we dealing with, some sort of acute peripheral issue versus something, central stroke that we worry about, things like that. So, I hope you all are familiar with this literature. If not, don't worry. We'll definitely do a future journal club to, focus more on this. But I know that your kind of streamlined exam is probably going to have to look a bit different. We kind of tend to talk outpatient because that's the majority of vestibular clinicians out there working in outpatient. But, we really appreciate and support all settings. And hopefully you find that with the right patient, you could use a gait disorientation test in acute care for the right patient, depending on, kind of how they are doing functionally. It may be, something that could be helpful to you. So just keep that in mind as well. Let's get through some of this. So take-home message. It's definitely a great test, very simple, easy to do, the gait disorientation test. Highly recommend personally. And, the huge, value, you mentioned how strong it is. So, get out there, make sure you're using it. And again, a lot of you are already doing it, but you just didn't know you were doing it. So now you can do the math and add that into your documentation and your exam, wherever you are. So this is some contact information for our speaker and all the wonderful things that he has done and continues to do. And we're going to hit up a couple questions. So
Sure.
here we go. All right. So one question is, when findings are positive for saccades, like I guess abnormal saccades implied, what does this point you to? Ooh.
Oh, yeah, that's a whole podcast right there, Helena.
Yes, it is.
Yeah,
Yes, it
yeah.
is.
hmm So at its most basic level, if the test is done accurately and you get an abnormal result, it tells you that there's some sort of central nervous system involvement, right? That's one of the major reasons why we do an ocular motor exam with our patients, is to try to determine, is there a CNS component to this or not? Where the problem is depends on what the abnormality in the saccade is, and yeah, that's a whole podcast. Maybe you can get David Z on here. That would be great.
Well, I don't want to, let out any
Aim high.
secrets, but he might be on in 2023. I might have arranged that already. All right.
Okay. Heard it here first.
I know, right? Leaking it out. All right. So Robin Evans asks, with PT seeing more direct access, I feel this is very important to screen for central nervous system red flags with ocular motor screening and a HINTS exam. So she's kind of in agreement there.
Yeah.
And another person says many central issues, even medication effects, things like that. So we all agree there's a lot to look at. Robin Evans asks, are there any studies looking at a sensitivity of the RALP and LARP, which folks who are not familiar with that, it's testing anterior posterior canal, whether it's been damaged or not, the way that the kind of traditional horizontal head thrust test is really testing the horizontal canal. If the horizontal test is negative, how is the sensitivity on that RALP and LARP at that point is what I see her asking.
Yeah, that's a good question. So in general, the sensitivity for the positional tests is not particularly great. So it's, again, if you have a negative Hallpike test, for example, it's not necessarily telling you that the person doesn't have BPPV. It may be that you're seeing them late in the day and they've habituated throughout the day.
Right.
Yeah.
What about for the head impulse test for the posterior anterior canal?
Yeah, they perform similarly or not as good as the horizontal test. It's harder to perform them.
Got it. So just kind of more getting that technique down for those kind of. Got it. Yeah. So. Doesn't mean you can't try to do it for those out there who have had some training on doing those. But if you get a negative, doesn't guarantee. Is that kind of what you're saying in summary there? Yeah.
Exactly.
All right. Okay, makes sense, says Robin. All right, cool. I think we got the test about saccades down already. I don't see any additional questions out the gate. I'm going to ask one of mine. Of course, I always have a huge list.
Sure.
What do you think would happen for patients with central vestibular issues if you gave them a gait disorientation test?
Yeah, I think they would struggle with it too. We just haven't shown it yet, and so I would expect something to come out on that in the future. But we're dealing with processing of vestibular information, and whether that processing is disordered because a problem with the ear itself, or disordered because of how that information is passed from one part of the nervous system to another. It still ends up with impaired processing when it's difficult then for the person to interpret that information, so they're going to be lost in space. So,
right.
Yeah.
No, definitely. How would you say that a person could apply the results of a gait disorientation test to treatment planning, if at all?
Yeah, that's a good question. So there's this tenet in physical therapy that the test becomes your exercise, right? And I certainly have had individuals practice sort of navigational exercises as part of their therapy plan, but I don't necessarily, give them the gait disorientation test as their exercise. It's what you're finding with the test is that it's a marker for how well a person is oriented and can navigate through the world. So I will give people Um, Things to practice like plotting out a pattern on the floor that they have to try to walk with their eyes closed, and then make it simple at first. Maybe it is a straight line at first, and then maybe it's, they walk a certain distance, make a right turn, and then they're supposed to stop, before they get to, the Kleenex box that's on the floor. So I do try to train spatial navigation. There is some evidence that spatial navigation responds to vestibular rehabilitation, but those studies are older for the most part, and most of them, didn't actually. They looked at just what's the impact of plain old vestibular rehab on outcomes in spatial navigation. So they didn't actually train it. They just looked at, what does basic rehab do? So I think, that's sort of a convoluted way of saying that I think if somebody is disoriented when they walk, that you can train it.
Mm-hmm.
And, we know that if they change by more than 3.7 seconds on the GDT, you can say that they've made a significant change.
Sure. Perfect. All right. Quick last couple questions here. We're going to say any correlation to the side of the lesion and the direction of veering. This is a common question.
Yeah, that's a good question. Oftentimes patients will veer towards the side of their lesion. That's pretty common, but it depends in part on their state of compensation.
Mm-hmm.
So as compensation progresses, that might switch. So, yeah.
Good point. Last thing. Is the GDT meant to substitute for other tests or add to the toolbox? Thoughts on that before we wrap up here?
The toolbox.
Your toolbox of testing. So do you think the GDT is substitutes for another gait test, or do you see it as kind of a supplement or kind of something that just has extra value?
Yeah, right. I mean, right now its main value is to help you determine if the person has vestibular loss or not. So, for example, that person that you've done the head impulse test and it was negative, you've done after head shaking nystagmus and it was negative, but you think that there's a vestibular problem here. Chances are pretty good that they're going to be abnormal on the Gait disorientation test, and that can then give you some evidence to say, yes, there's a vestibular disorder here. And then you have to decide, is this someone that you're going to refer for further testing? Are you going to treat? Are you going to refer and treat? Then you have to use everything that you've learned about that patient to decide what your next steps are.
Perfect. All right. Well, that was fantastic. Really helpful. For those who this is all brand new information, keep digging in, reading articles, taking courses. You're doing great. For those of you for whom, this is all familiar stuff. Obviously, you should have picked up a thing or two new, I hope, because there is so much in here. So thank you all for listening and taking the time. Everyone says thanks. Fabulous. Great job, of course. Dr. Grove, that's all to you. You really led the way here. So thank you for all your research, all your work. We really appreciate it.
Thank you so much for having me, and thank you everyone for engaging either through the chat or by asking questions. It's great.
All right, perfect. Well, we're going to hop off here, but thank you everyone for the thank yous, and we'll see you in December to talk concussion. Have a great rest of your day or night.